Good morning, everybody. I'm going to present my case series on pneumatic iridodialysis repair. So iridodialysis may occur secondary to ocular trauma, but or inadvertently during intraocular surgery, and it is reported to occur 0.2% after cataract surgery. If the tears are small, we may actually leave them as such, but if they are large, they may cause glare photophobia, and so they require reapproximation. Various suture-assisted techniques have been described, but they are technically demanding and they require surgical expertise and they can cause certain problems. So 20% sulfur hexafluoride or SF6 is an inert isoexpansile gas that is commonly used as a retinal tampering agent as well as for desmetopexy. It is said to absorb over 2 weeks and it has been described for iridodialysis repair, but there is little peer-reviewed literature. So we describe the results of this minimally invasive iridodialysis repair in 4 cases. So what we did was a well-informed and free-will consent was taken from patient. Intraoperatively, whatever complications happened, patients were informed that we are going to do this. So for those where patients were taken for second sitting, we had done cleaning and draping and aseptic precautions. Side port was made opposite to the side of iridodialysis. Entire AC was filled with 20% SF6 till the iris was convex down, and this tamponade was maintained for 5 minutes. AC was decompressed after that to fill 2/3 of its volume, and side port was then hydrated. Appropriate posture was maintained for first 24 hours. Topical antibiotic steroid combination with cycloplegic homatropin was given for 1 month. So first case was of a 77-year-old female patient who was referred to a center for iridodialysis repair on 3rd day after SICS. The patient was pseudophakic with a well-placed PCLin bag. The primary surgeon noted a 4 clock hour large supranasal iridodialysis during crystalline lens delivery from superior scleral wound. So we injected this SF6 20% and then we advised her head and elevation for 1 week. On next day follow-up, the iris was found to be attached to the root. So this was the case that was sent. This is a preoperative photograph. And this is the intraoperative photograph where we injected SF6 and we can see that pupil is more or less round. This is day 1 postoperative photograph. We can see SF6 is forming a big bubble and the pupil is also appeared to have gone back. This is at 1 month follow-up. We can see that almost near normal pupillary iris configuration is maintained. This is the patient's gonioscopy that we have done. We have done that iris was round, but there was a small gaping of this at iris root, but this did not cause any problem to the patient. It was only visible on gonioscopy. In case 2, it was a 65-year-old female patient who suffered an inadvertent 270-degree iridodialysis while crystal lens delivery during SICS. So after placing PCLin bag, the iris was gently reposited with an iris repositor and the same technique was followed. The patient was advised foot end elevation for next 1 week. There was an approximation of iris to its root from either side of the tear with a residual tear from 4 o'clock to 10 o'clock. This fell in the aphakic area, so no second surgery was taken for iridodialysis repair. So I'm sorry I don't have its intraoperative photograph, but this was how the tear was there. It was reposited back, and this is how after 1 month we can see that it is just reduced to a smaller inferior 1 quadrant area which is falling in this aphakic area. So the patient was not symptomatic, so second sitting was not taken. In case 3, it was an 18-year-old male who presented with 180-degree supranasal iridodialysis from 10 o'clock to 3 o'clock after blunt trauma with a cricket ball. The patient was a phakic with clear lens. So for this patient, 20% SF6 was injected intracambrally under peribulbar anesthesia, but the iris did not get reposited, and so immediately a suture-assisted repair was taken. In this suture-assisted repair, we found that there was an intraoperative lens touch with suture needle, but at 1 month follow-up, it was not significant. So the patient had 6/6 vision. So this was the case. We can see such a big iridodialysis was there. We tried to reposit it with SF6 20%, but it could not be reposited. So immediate suture-assisted repair was undertaken. At 1 month follow-up, we can see a round pupil, completely clear AC, and there was a small cataract, but it was not visually significant. So we did nothing. In case 4, again this was a 68-year-old male patient experienced 4 clock hours inferonasal iridodialysis while undergoing SICS during lens delivery. Again 20% SF6 was injected after repositing the iris bag and placing iolin sulcus. Patient was advised foot end elevation. Only 1 clock hour of iris remained unattached at 1 month follow-up as the patient did not have any symptoms, so second surgery was not undertaken. This was the case. You can see that there is such a big iridodialysis that is noted intraoperatively, and after SF6 injection, this is on day 1 poster, we can see the iris is reposited well. So results are that in 3 out of 4 patients who had iris tear during lens delivery during SICS, we had successful reapposition of iris to its roots. Even though it was not complete, it led to an asymptomatic phase in the patient, so second surgery was not required. So there was no incidence of eccentric pupil. Gonioscopy also showed a well-attached iris. Maybe some gaping was noted in these cases. So other than that, there was no much of AC reaction, no rise of intraocular pressure, or no redetachment of iris noted. So this is the case detail that are summarized. So the positioning posture of the patient was importantly maintained according to the presence of the iridodialysis area. So in those cases where the head end elevation was given, where there was inferior iridodialysis, superior iridodialysis, and where there was inferior, then foot end elevation was given. So we believe that this entire technique depends on the presumption that iris will follow its natural anatomical course to get reapproximated to its root on injecting SF6 from above. Unlike a tractional pull which is happening from a suture, here it is following its natural course. So with SF6 providing further tamponade for next 2 weeks, adhesions are expected to form between iris and its root, and thus leading to a permanent refixation of iris without the need for any sutures. So we can see this. So it is important that we had certain limitations also, like there can be expansion of SF6, but here we do not have any. But because we reduce the AC volume to 2/3 of the SF6 filling. So its failure in this young male with post-traumatic iridodialysis suggests that thick elastic iris and anterior curvature of crystalline lens prevent spontaneous reattachment. So making them unsuitable for SF6 repair. In young patients, it may not be very successful. So we can tell that we had 75% success rate in our patients. It is helpful in elderly pseudophakic patients with thin atrophic iris, especially with iatrogenic tears accompanying cataract surgery, especially in novice surgeons where they may not be possible to, they are already in panicky state, they can only inject SF6 and leave it like that. So we believe this technique carries potential of outpatient iridodialysis repair procedure that can be even attempted on slit lamp, but requires further studies. Thank you.
Nice case, but
no audience question here.
Yeah.
No audience question. It's free paper session. I'm sorry, there's no audience question. Sir, it's a free paper session. I'm sorry, there's no audience question, which was earlier told by the chairperson.
So, though it's a limited case series, like in third case, you have to resort to suturing.
Yes, sir.
But like in second case, where the dialysis was inferior one, even after, almost 270 clock hours, 270 degrees. So there was still a lot of gap, and it was inferior. So patient must be having a lot of maybe photophobic symptoms. So what do you advocate after going through these 4 cases? Is it really worth it, doing it and waiting and watching and then go on to do a suture repair? And one more in addition to that, on the table, did you put any miotic or dilator agent? Though you do advocate homoatropine or cycloplegic post-operatively, but did you do any of the things like any miotic or so that there could be unrolling, which may be difficult once the dialysis is too large?
Okay. So first, your first question, whether it is worth it. Sir, from my experience, I have really found it worth it, even though I have done it in 4 cases. In all those individuals, this is the case photograph that I am showing where the inferior dialysis was big enough, but the patient did not have photophobia, maybe because it was falling through the aphakic area. It was not in the phakic area, so the light entering the eye was less. The patient did not have much of glaucoma or anything, which was with 270 degrees iridodialysis. If we take a big repair in the 70 years old individuals, then the chances of second surgery, the sutures and all that itself carries a lot of problems, and it requires a lot of surgical expertise. While this is a very simple one where we inject SF6 and leave it to take care, I may say even if you require second surgery, the amount of suturing required for second surgery will decrease dramatically even if the surgeon wants to undertake second surgery. Secondly, novice surgeons, especially those who are doing SICS, they are quite panicky in that state. So they do not know what to do. They can't suture it at that time. The wound is large. They cannot make the scleral pocket to make a, bury those sutures, prolene sutures. So in that case, just repositing and leaving with SF6 will help them in some way, at least in the future. Even if they require a second intervention, the chances will be less. In our cases, we did not require because the patients were elderly. They did not have much of complaints in the future. So we left it like that. But had some patient complain, then we would have even undertaken a suture assisted repair in the second sitting, sir.
Okay.
And then